they received a grant of $350 million to accept responsibility for all of the Medicaid population. And this is what is happening throughout the industry today, between mergers of multiple institutions, being asked by government to go at risk for the populations and take both the economic and the quality into consideration for improving our entire healthcare industry. The federal government is starting to catch up, and even the commercial insurance companies are beginning to participate in this risk-taking process. But in order to achieve this, we need very large organizations like Northwell, Montefiore Medical Center, Columbia-Presbyterian Medical Center, Mount Sinai, merging multiple hospitals in order to go at risk. And the insurance industry has known for years that to effectively go at risk, you need in the order of magnitude of 10 million people in your population in order to spread the risk across that population. So healthcare is going through this transformation where we are merging multiple industries into single entities in order to better understand and manage the outcomes of our institutions. As the example, Northwell is now 63,000 employees, the largest employer in the entire state of New York. It has 18,000 physicians in their system, and they're covering approximately 16 million lives across the lower New York region. Certainly everyone is trying to migrate into the same similar model, which can be characterized by the Kaiser Foundation in California, or Intermountain Healthcare in Utah, or Vanguard Health in Texas. This is a total transformation of an entire industry that we have not seen for the last 30 years. But we have been through this. And being in healthcare, I've studied the history and the evolution of healthcare from the 1890s to the present day. And it's given me the perspective to work very closely with the top leadership across the entire industry. And for you students, I wanted to encourage you to join professional organizations related to the industries that you're interested in, such as the Health Leaders of New York and the American College of Healthcare Executives, which are facing these very same problems across the entire spectrum. So perhaps I can just fill in some questions and see if we can open up the discussion. Dr. Singleton?
That sounds great, Paul. Thank you very much for that really interesting overview of your career, which has really, really been successful. I'd like to open the floor up now for questions from the audience. You can raise your hand using the raise your hand function of Zoom, or you can put the question in the chat function. Either way you'd like to do it. I'd like to begin while the questions are coming in, ask one myself.
Sure.
You mentioned about the current pandemic and how we've responded to it a little bit. I'd like, from your background, your experience, what would you like to see the administration and other decision makers do now?
Well, certainly I'm very much in favor of vaccines. And certainly I would like to see the FDA and the CDC move as quickly as possible to open up vaccinations for children. We can talk about measles or any host, or polio, or any host of other diseases in which vaccines are required among children. And that really seems to be the nearest horizon that we could be facing. Certainly the mask debate is certainly problematic. And as more and more people are saying, it's not about protecting yourself, it's protecting everyone else around you. So the language, the politics is so disheartening. And as I mentioned before, the Berger Commission wanted to close 46 hospitals in the state of New York. Many, many people lost their jobs. But when all was said and done, the Berger Commission simply went to the legislature and said, we can close all these hospitals. We can close no hospitals, but you're not going to have the choice about which hospitals we close. The politics have to be put aside, and we have to look at the public health issues as paramount. Here in Westchester County, we have an extraordinarily good commissioner of health that identified both the AIDS epidemic as well as the coronavirus epidemic and a Legionnaire's epidemic year after year after year. We have the understanding of how this actually works. We just have to be responsive as positively as possible. Excellent.
Yeah. Your business is very focused on analytics and the use of data to make decisions. A lot of things that we do in the Lubin School of Business include data analytics, the use of analytics tools. Would you talk a little bit more in detail about your work in that area so that students can learn a little bit more about that and what they should do to prepare themselves?
Yes, absolutely. I very much appreciate it. And I actually teach this very subject at Hofstra University. I created a certificate with the New York State Department of Education for data analytics. In the case of healthcare, it really is first and foremost, what is the source of the data? And how good is the data that we're working with? The New York State Department of Health, almost 30 years ago, created what's called the SPARCS database. This is all the inpatient activity of hospitals across the entire state, where a copy of the billing record is sent to the State Department of Health, and we can see competitively what diseases are being treated in which communities, where the patients come from, what the cost of care looks like, and all the comorbidities that those patients represent. There are over 400 fields of data, i.e. variables, that we can evaluate. But this is one of the first things that I did at St. Vincent's Medical Center 30 years ago, was to look competitively, who are we servicing? Greenwich Village no longer had children as a primary focus. It became adults. And I really began to raise the question, why do we have a pediatrics unit in the middle of Greenwich Village when there are no kids? Why do we have a maternity service? And everyone came back and said, well, we have to do this. But to look competitively in the marketplace, and the closure of hospitals, i.e. the Berger Commission, was another perfect example. The other local hospitals of those that were closing could very readily absorb them because the length of stay and the technology of healthcare had changed. The length of stay of patients had been cut in half with the change in the reimbursement economic model. So we need to have a source of data in order to do the analytics. We then need to have an infrastructure to manage very, very large databases. I receive about 30 million records per year from the State Department of Health. I have a huge server to support 700 million patient records. And I need a team of people to help me manage this infrastructure and the data management. And then we get into the query language, which happens for me to be standard query language, SQL, which is a commercially available product to handle these very large databases. We then get into predictive analytics. And Dr. Hans Levenbach is my mentor from the last 30 years to do predictive analytics, to understand regression modeling, epidemiology considerations, seasonality of data, all of the tools that are required to do analysis of historic data, evaluate the quality of the data that we're looking at. Is it really complete? And then get into the predictive analytics and the simulation modeling and the artificial intelligence. So there's a team of people that I work with to make this happen. And certainly every industry is doing something similar with different data sources and different tools to accomplish this. Towards that end, we then have dashboards that we can provide to leadership of hospitals, that they don't have to understand what's going on behind the scenes, but they can begin to see visually what's happening on a predictive basis. What's going to happen over the last 18 months or the next 18 months? In order to do that, we need a history of at least 3 years, preferably 5, 6, or 7. And as I was doing one particular project, I tested the data to make sure that it was clean. And I identified that there were 37,000 duplicate records. Whoops.
That's very interesting. Yeah, and I welcome you to elaborate even more on that kind of stuff. But let me ask another question, and let me encourage other people to step up too. I'm sure there's a lot he can share that he hasn't talked about already that's of interest to this group. But you mentioned in your presentation about how there's been a lot of consolidation. You mentioned what's happening in California and Utah and Texas as examples. What do you see as the pros of that, as the cons of that in terms of the business? If any of these students want to go into the healthcare business, administration business, and what do you see in terms of patient care with this kind of consolidation? Pros and cons, if you could.
I see it as a very favorable turn of events. Hospitals for the last several decades have been a silo of activity. What happens in the physician's private practice environment has nothing to do with what's going on in the hospital environment. And it's only very recently that the hospitals and the doctors are actually sharing their records of patient care. This integration is leading us to preventative medicine. And reducing the occupancy of our hospitals is actually favorable. As an example, Montefiore Medical Center is actually able to make a profit on the Medicaid population, even though the reimbursement on average is only 62% of the real cost of care. But Montefiore and Health and Hospitals Corporation have been using the medical home model to reach into the patient's home to encourage preventative medicine. And this improves the quality of the outcomes, not 3 years later for the traditional insurance companies, but 20 years later. Kaiser Permanente has 30% fewer heart attacks and 40% fewer strokes in their population because they are emphasizing preventative care, such as effective diabetes care and hypertension care. You don't want to do those in the inpatient environment. You want to do it in the patient's home. And how do we integrate home care services, long-term care services, nursing homes, hospitals, physician offices, urgent care centers into a more cohesive model of sharing quality and information about the individual patients. Mm-hmm. So this is taking us in the right direction. It's a long road to go, and there are certainly many hurdles for us to achieve in the coming years. From the employment point of view, every executive is looking for people who are oriented to this more comprehensive systems perspective. And that's why I think our universities are spending more and more of our opportunity and resources to try to accomplish that, both at the nursing level, as well as the physician level, as well as the management levels.
Very interesting. No question.
I have a question.
Yes.
You have achieved so much. You are very successful in your career. What advice would you have for students who want to follow your path?
I'm already emphasizing in my presentation team management. Don't go out there and think that you're going to pull all of this by yourself. Identify what the needs are in your respective field of expertise. when I was in materials management, I needed a microbiologist to teach me about sterilization. I needed the nursing staff to teach me about what happens in the operating room. And I had been there many, many times. It's difficult, it's time consuming, but you really have to develop interpersonal relationships. And my background with Norm Metzger as the Vice President of Human Resources really set me in that direction to work with other people as a team.
Well, I'll ask a question.
Yes, Kim.
This has been fascinating. I want to know, this isn't my question actually, but I just thought of it. Are you going to write a book? I mean, there is so much here. But when in hearing you speak, it seems to me as your career went along with data analytics becoming over the last 30 years a huge part. I don't believe that when you started out, it was a big part of what you did. I mean, I know you're an engineer and you probably dealt in that scientific analytical world, but it seems like the convergence of all this data and the merging of all these healthcare systems together. What is driving, would you say, the decisions in these mergers? Is it cost the bottom line, or, you know, you talked a lot about prevention. Is it patient care? And I'm also thinking about the doctors. How has the doctor's role, the physician's role, has to have changed dramatically with what they are expected to report and I guess record, as you know, I've seen it as I've gone through the years seeing doctors. They're not just giving an exam, they also sitting there on their computers. So I know there's a lot there, but it's just so interesting to me. Which came first, the chicken or the egg, the transformation of the healthcare system, or the in and of itself because it needed it, or is it all driven by data? Is it all driven by data, and should data always make all these decisions?
Well, allow me to first emphasize the decisions are not being made by data. That in 1979, Professor Averill at Yale University was asked to identify, is there a correlation between the length of stay and the cost of care at Yale? That was the first time the question had been asked. And a university professor then did regression analysis on those two variables and identified correlations for 468 disease conditions that identified length of stay equaling cost. Those were the development of the diagnostic related groups. But when it was presented to physicians, the physician said, wait a minute, there is a difference between eye surgery and ear surgery. They were exactly the same number in the correlation analysis for eye surgery and ear surgery. So Professor Averill simply said, okay, I'll create another category. And 3 years later, New York State adopted diagnostic related groups. We ended up with a fixed reimbursement for 472 categories of diseases. And within 18 months, the length of stay of patients was cut in half because we didn't have to have those patients in the hospital for all those days. We were being reimbursed based on the length of stay. And that incentive overnight went away. It is economics. We do have to control the cost of healthcare, and the cost of healthcare in the United States is twice as expensive as anywhere else in the world. It has to be about cost. But certainly from a political point of view, we want it to be about quality. And we can improve the cost of healthcare, i.e. Kaiser, by not having people have heart attacks. not having strokes. That's an improvement in the quality. But the commercial insurance companies the employers that pay the commercial insurance companies will change their insurance company every 3 years for a lower premium. There is no incentive in the commercial insurance world to reduce the cost of healthcare or improve the quality of healthcare when they change insurance companies every 3 years. We need a long-term, loyal perspective to the institutions that are providing the care and services in the community. Johns Hopkins effectively is the only hospital in Baltimore. They control everything. Philadelphia has coalesced into 2 institutions. Boston, the entire Massachusetts, has 3 institutions. It's about institutional loyalty, and the physicians really become paramount in identifying the quality of care, which we are now and only just recently actually measuring the quality of the care coming out of the individual institutions. So it really is about oligopoly and making it a more efficient and more effective system. I'm an engineer. I think you can see that. I'm an engineer first and foremost, and I'm understanding after 50 years of experience how these pieces play against one another. Is it simple? Hell no. It's very complicated. I hope that helps, Kim.
No, very interesting. I mean, I could go on with other questions, but it is very interesting. I mean, I think too, when thinking about the students and your career, I mean, I would love to know, as you've gone through a lot of these transitions from Bridgeport to St. Vincent's out to Westchester, in terms of your leadership style, do you take your teams with you, or were you retraining and working with new teams to get these different major, which often sound like overwhelming initiatives done at these major institutions? Or I'm curious about that.
Yes, in each case, I've had to train or work with or learn to work with new people. And I have had the opportunity to get involved with regulatory affairs in Washington, D.C. and standards within the industry. I've gone out and recruited people such as a microbiologist to help me with this teamwork. I also have been in the situation of not being able to hire new people and had to train and orient new department heads and new people that I was working with on a day-to-day basis. Trying to emphasize the idea that I'll perhaps have 6 or 7 key people that I'm constantly working with, but to have a division of people working for me that measure 60, 70, 80, 100, 200 people is certainly the expectation. But to develop a close team of associates that I work with on a day-to-day basis has really been my management style.
Paul, as a follow-up question to that, when you're meeting with candidates for your executive team, are there some key things that send a red flag that ultimately give you a pause?
A red flag? Yes, certainly the Peter Principle. If someone is demonstrating that they want to have control over everything that they touch, that's a problem.
Let me jump in again. Would you talk a bit more about technology? I mean, you mentioned SQL a little bit earlier. Are there any particular tools that you would recommend students become familiar with to analyze data in the healthcare business? I mean, things like Tableau, for example, or
Absolutely.
There's a lot of tools out there that we use, that we teach our students in Lubin programs. Are there any particular ones that are particularly well suited for healthcare?
I have a long history with SQL, and the students probably might not recognize that Access is the same data management software. It's just that it has limits on the number of records and the number of fields that it can access. Because it's an economic decision by Microsoft, they want to sell the commercial version of the same software. The same goes for Excel spreadsheets. There are limitations built in so that Microsoft can collect more from Tableau. The visualization of the data is very important. The data mining is very important. And R and Python and Tableau and SQL and et cetera, et cetera. Yes, there are many programs that I'm not that familiar with. And that's exactly why I reached out to a PhD scientist from IBM Watson to help me with the artificial intelligence. I don't have that expertise. I don't ever expect to be able to do that. But to develop the network of people that I can work with, Claudia Pellish, I just mentioned from Watson, is a PhD statistician with this expertise. Build a team around yourself to be able to handle the more sophisticated. For myself, there's actually within SQL a point and click capability that will write software for you. I don't actually know the language proficiently. Frank Struble is my partner, that when I get into the more sophisticated stuff, hey, Frank, give me a hand with this. All right. Again, I'm emphasizing the teamwork, the infrastructure, the environment in which this work is done. You need someone who understands the infrastructure of the computer technology. And my computer technology today is about 20 years old. I have to replace everything I have. And we are contemplating going to the cloud because the databases are no longer 30 million records per year. We're looking at 1.2 billion records per year with the all claims database, including the physician office activities. Optum has taken over the entire infrastructure of the New York State Department of Health because they can no longer run an IBM 370 computer because the last man who could program it retired. This is the changing world. The infrastructure is changing. The software is advancing tremendously, but we need teams of younger people to help us put all these pieces together. The basic questions about the quality of the data is still the same. Asking the right questions of the data are still the same. Visualizing the data and forecasting and having the confidence that what we're saying is actually the case is really paramount.
I have a question on behalf of the students. You've mentioned a lot that teamwork is very important, but when it comes to looking for internships, that's something that they have to work on individually. They're on their own for that. Do you have any tips for students as they look for jobs and internships that'll make them stand out?
Yes, I appreciate that. I myself, during my junior year, attended a conference where someone like me was presenting, and I approached him after the conference and I asked, could I do a work measurement project at your hospital? Some class that I was taking that would be applicable to industrial engineering. And lo and behold, 18 months later, that led to my career. So really have an open mind and don't be afraid to approach individuals that you might see or might have an interest in some dimension of their business. That's exactly how I started out.
And would you say that holding a graduate degree opens more doors?
Yes, absolutely. And certainly it has to then be a little bit focused more on what the actual job description might be for that student. Networking across people is really paramount, and having a well-written resume becomes important. But building off your undergraduate work, working on an internship, and even in your graduate program, having an internship is certainly a valuable resource.
So I was wondering what actually draws you to healthcare administration, and what type of student you think should pursue a career in healthcare administration?
Dave Folker, who gave that presentation to me, was describing how far behind the healthcare industry was in doing industrial engineering, or management engineering as it's known in this industry. The efficiencies, the operations management, the improvement, healthcare is still far, far behind. I was describing the mergers and the acquisitions. This is a new field, but I was intrigued by someone saying he was from the fabric industry and transitioned into healthcare and found it a tremendous opportunity. It's still the case. Banking has moved forward in the information systems technology, investment world. Other industries progress at different stages of development, and healthcare is still relatively far behind other industries. So there are opportunities. And certainly in the whole management field, the emphasis on team management is really very important to doctors and nurses and in operating rooms, laboratories, pharmacy, every industry that you can imagine. We actually have some specialized department within the hospital that needs management skill and capabilities. So I would really encourage you to take an interest in some particular field. It might be medicine, it might be pharmaceuticals, and there are opportunities both in the major industry of pharmaceutical, but also within our hospitals and our organizations. I hope that helps, John.
Yeah, to add on to my question, what type of specific MBA do you think a student interested in this career path should pursue?
I have been looking very closely over the last 6 months at the Masters in Public Health, the Masters in Health Administration, the MBA programs, as well as a couple of the other specialties such as pharmacies and others. But there are 3 major management disciplines. The MBA will probably cover a bit more of the economics that I mentioned. The health administration is going to focus on the interdepartmental activities. And the public health is going to focus, of course, more on epidemics, such as we're experiencing right now. These are different disciplines, but they are very much aligned with one another. And frankly, many of the universities don't necessarily understand the differences. Hofstra University is the only one that has all 3 of those disciplines currently in their curriculum.
Okay, thank you.
I believe, Amanda, was it you that had a question?
Yes, I do have a question. Well, I want to congratulate on your phenomenal success. So right now I'm going through a career change. So I personally was working as a nurse during the pandemic. I'm a pediatric nurse. So right now I'm guiding towards more of Lubin School of Business, and I want to know your everyday basis of what you do as a management, specifically in healthcare.
I very much appreciate, especially the decision that you're about to make. My master's degree thesis was actually about nursing management. And what I found in my thesis work is there are 3 types of nurses. There's the bedside nurse, there's a management nurse, and there's the educator nurse. And never the 3 shall actually be the same. They are very different personalities, and I get it. With
There's a lot.
Yes, with the clinical experience that you have in pediatric nursing, I would certainly encourage you to get foundations in management. And that could be a tremendous opportunity for your growth. The personality differences between bedside nurses, and I wanted to emphasize, my own sister is now the director of the emergency room in Portland, Maine, in Maine Med. She has spent 50 years of her career in healthcare as a bedside nurse, and only now has she progressed into management. She hates management people with a passion. I get it. I understand. She is a bedside nurse. Thank you, Amanda.
Okay, thank you.
Okay. Well, I want to thank you very much, Paul Savage, for being with us today. You're a very successful alumnus of the Lubin School of Business, and we appreciate you taking your time to be with us today on the Dean's Roundtable. We have a small token of our appreciation to give you, but unfortunately, I can't hand it to you over Zoom. So it'll be on its way to you soon to your home. But thank you very much for being with us this afternoon. And thanks all the students for being here with us this afternoon as well.
This has certainly been an honor. I very much appreciate it. And I certainly look forward to hopefully working with you again soon.
Sounds great. Thank you very much, sir.
Thank you,
Have a great
everyone.
afternoon,
Thank you.